Hi everyone, welcome back to Goggle Doc's second episode in our heart failure series. So if you remember, we left the first episode on a cliffhanger with our case study, and we're going to be carrying on through that case study today. But before we get going, I'll just quickly go around the guys. We'll all introduce ourselves again. Kevin.
Hello everybody, Kevin Fernando here again, GP partner, North Berwick Health Centre, just east of Edinburgh.
Amar Patana, a consultant diabetologist in the West Midlands.
Patrick Holmes, GP partner in Darlington.
And I'm Amrit Lambert, GP based in North London. So Kevin, I'm going to hand this straight over to you for you to update us on what's happening with Fatima.
Absolutely. As you said, we sort of left things on a bit of a cliffhanger in the last episode, but just a quick recap. Fatima, a 55-year-old lady who's been living with type 2 diabetes for over 10 years now, presented to us in primary care with progressive shortness of breath on minimal exertion, 3-pillar orthopnea, and evidence of some pedal edema as well. Examination, pulse was 84, regular, BP was elevated, 162 over 94. Auscultation actually just revealed some sparse bibasal crackles, which largely cleared on coughing. Heart sounds were fine, were dual, no added sounds, and the JVP did appear a wee bit elevated. We did a ECG, showed sinus rhythm, but evidence of LVH, left ventricular hypertrophy, and some Q waves anteriorly. So, of course, we all suspected heart failure, so we organized for her to have some further tests, further bloods, including an NT-proBNP. And that actually returned at over 2,000. So what do we do next for Fatima in primary care? So I know in Scotland, we tend to follow SIGN guidelines, but we did have updated NICE guidelines, didn't we, on the management of heart failure published a couple of years ago. And certainly an NT-proBNP of over 2,000, it's recommended by NICE for an urgent 2-week referral to a heart failure service. Is that right, Amrit?
Yeah, absolutely. So as you said, the NICE guidance were updated in 2018 for the management of chronic heart failure. And yeah, so with Fatima's case, her NT-proBNP being over 2,000 would put her into that category that requires an urgent review in the heart failure service within 2 weeks. And that's actually what our local guidelines reflect as well in North Central London. So certainly aligned with that. Whilst we're on that topic, we're going to pop up a table now, which will summarize essentially what NICE recommends. So levels less than 400, well, in these situations, you can be fairly confident that heart failure is not the cause of this patient's symptoms. And NT-proBNP has quite a strong negative predictive value, so in the region of around 90%. But then between 400 and 2,000, well, any results within that range would be referring the patient again to the heart failure pathway, but to be seen within 6 weeks. And then as we mentioned with Fatima, with her NT-proBNP being above 2,000, that warrants an urgent referral that requires her to be seen within 2 weeks. We know that not all areas of the country use NT-proBNP yet. So the table does refer to the values that would correspond to those different groups as well for BNP. But today we're going to focus more on the NT-proBNP side of things. Now, Patrick, there are some considerations, aren't there, in terms of when we get that result back on our computer, things that might, need a bit of thought if they don't quite correlate with the clinical picture in front of us.
Absolutely. Funny you should ask me that question, because I've been chatting to my local colleague and professor in primary care cardiology, Professor Ahmet Fuat, and you can hear me and him discussing it just now. Hello, Ahmet. Hi, it's great to again meet you virtually. For those people tuning in, I've known Ahmed now for 22 years, for the time I've been a GP in Darlington, because he's also been a GP within Darlington. Ahmet has got a huge, extensive experience of primary care cardiology. He's a professor of primary care cardiology at Durham University, as well as a partner in Darlington at Carmel Medical Practice. He's been heavily involved in the Primary Care Cardiology Society. I believe he's certainly a past president. I think has an emeritus position now within that organization. And of particular value in terms of some of the questions we're going to be asking today is Ahmet, actually, I know for his dissertation, for his PhD, did a lot of work on natriuretic peptides at a time when I didn't even know what natriuretic peptides were. So, so has been heavily involved in terms of research, particularly focused on utilization within primary care as well as secondary care. So, Ahmet, is there anything else you want to just say in terms of your own introduction?
I'm actually education and research lead on the Primary Care Cardiovascular Council. And just to say that if anyone does want to join the organization, it's free to join. pccsuk.org, and we've got over 1,200 members now with lots of good educational resources on there, including around heart failure.
So Ahmet, just going on to some of the questions I'd like to ask you, tell us what's the difference between BNP and NT-proBNP?
Yeah, I mean, basically the natriuretic peptides, the most useful one is B-type natriuretic peptide. Used to be called brain natriuretic peptide, a phrase I don't particularly like, but mainly because it was first discovered in the brain of rats. So it is a protein peptide that is in the human body and most other mammals. ProBNP is the sort of inactive peptide that sits in the cardiovascular muscle, and most of it sits in the left ventricle. When the heart comes under strain, so if it's overstretched, you know, if there's an increased afterload or preload, and of course, heart failure is one of those conditions that can cause both, then what happens is the proBNP is cleaved into its active moiety, which is BNP, which has a physiological function, and I'll come back to that, and into NT-proBNP, which is the inactive moiety. Both can be measured in blood, and both go up in patients with conditions like heart failure and others. So what BNP then does is it tries to compensate for the stress that the heart is under by leading to vasodilation, to increasing sodium excretion, so and water excretion, so increasing diuresis, and it has an effect on endothelial function. So because it's raised and it's easy to detect, you know, we can measure that in plasma. The reason that NT-proBNP is preferred by the NICE guidelines is that it is more stable in blood for longer. So, you know, if you're taking a blood sample in, you know, say in our area way out in Barnard Castle or Middleton and Teesdale, it may take several hours to get to the lab in Darlington or Durham. NT-proBNP is more stable at room temperature. And there's more evidence from clinical trials in both its diagnostic utility and to a certain extent its prognostic utility. So they're the basic differences. Having said that, BNP itself is easy to measure, and You know, if you don't have NT-proBNP in your locality, then BNP can be used too, but with cautions if you're keeping it in a tube overnight or traveling a long way.
And in terms of using natriuretic peptides, what pitfalls would you say they are in terms of using them?
Sure. I mean, what I'd like to do is take a step back, actually, Patrick, and say that they are incredibly useful. They've got much better negative predictive value than an ECG, and we can perhaps come back to that. And that's why they're recommended by virtually all national guidelines for patients with suspected heart failure in particular. But what we need to do is make sure we're using them appropriately for many reasons. You know, yeah, they're not that expensive, but they're also not that cheap. 12 to 25 pounds, depending on the lab. You know, only use them if you truly suspect heart failure. Don't just add it to a profile because someone's got CHD. They've got to have signs, or well, symptoms and or signs. So if someone is short of breath, they have peripheral edema, they are getting short of breath lying flat, orthopnea, waking up at night gasping for their breath, paroxysmal nocturnal dyspnea. And in particular, if they have a comorbidity that increases the risk of heart failure, then we should check them in our workup of that patient. So as you know, Patrick, I mean, certainly in my own practice and some other Darlington practices, we do advise our nurses to ask about symptoms of heart failure in long-term conditions clinics, because we're seeing about 90% of those patients annually. So if a patient has hypertension, existing coronary artery disease, atrial fibrillation, diabetes, COPD, CKD, previous stroke, then we would ask the questions. And if they have peripheral edema, if they're short of breath, use natriuretic peptides. We shouldn't use them to monitor heart failure, and there's no point in using them if you've already got a diagnosis of heart failure. Once they've been done, if they're raised, the higher the level is, the more likely the patient has heart failure or a significant cardiac problem, which is why the national guidelines say a level of over 2,000, refer urgently within 2 weeks, a level of 400 to 2,000, refer urgently within 6 weeks. But what we need to be aware of is that raised natriuretic peptides do not necessarily mean heart failure, because natriuretic peptides go up with age, and that's why some areas use age-related cutoffs, because patients over 75 tend to have significantly higher levels than those under 75 or indeed under 50. Sex doesn't make much difference. There's a very slightly higher level in females, but other conditions can raise natriuretic peptides. So someone with significant hepatic impairment, CKD 4 to 5, so significant renal impairment, patients with atrial fibrillation, recent acute coronary syndrome, patients even with significant left ventricular hypertrophy, hypertensive, can have raised natriuretic peptides. So we need to be careful not to tell the patient they've got heart failure, but say, something's going on, we need to refer you for investigation. The reverse of that is that obesity, especially a BMI of over 35, 40 in some studies, may reduce natriuretic peptides below the diagnostic cutoff level. So if someone has a BMI of over 35, they have, significant symptoms or even signs that suggest heart failure, even if natriuretic peptides are normal, I would refer those patients on for either open access echo or to a clinic if it's available. We did do a study a few years back looking at various things that affected natriuretic peptide levels. The only thing we found was age that made a difference. Even being on pharmacotherapy that's used for heart failure, although it does lower natriuretic peptides, so a decent dose of ACE, ARB, spironolactone, eplerenone, and Tresta beta blockers does lower it a bit, but it doesn't tend to lower it below the diagnostic cutoff, unless the patient has very, very mild heart failure. And if that's the case, okay, you miss a few, but it will eventually surface.
One thing you talked about before was the negative predictive value of ECGs and and natriuretic peptides. So do you want to just briefly just cover that in terms of the importance of an ECG within that initial assessment, and what a normal ECG means in practical terms?
Okay, yeah, I mean, it's you'll see that in NICE guidelines, natriuretic peptides have taken, are in the guidance that you must do. ECG should be done because it gives us other valuable information. In terms of the ECG, there's nothing specific on an ECG that can diagnose heart failure. I know that may sound, talking down or, be a bit condescending, but surprisingly, I do sometimes get referrals that say, does this ECG show heart failure? It can't show that. But if the patient has atrial fibrillation, if they have left bundle branch block or an intraventricular conduction defect, if they've had an MI before or have ischemic changes with significant T-wave inversion, etc., then they're more likely to have heart failure. So it gives us valuable information. But in terms of the, probably 15, 20 years ago, guidelines used to say, and many people used to say, that if you have a normal ECG, you don't have heart failure. That's not true. And there have been various studies, including a study that Jerry Murphy and I did, and many others, and I looked at this during my PhD, that in various studies, and the one that showed the biggest discrepancy was by David Sandler, a cardiologist in Chesterfield, where 27% of patients with a normal ECG had left ventricular systolic dysfunction. So, it's not as good a negative predictive index or value as natriuretic peptides, where the negative predictive value is about 98% with NT-proBNP. And it's for that reason that NT-proBNP is the primary test. And areas that say you can't have an echo because you've got a normal ECG, hopefully they're disappearing. And what we're using to guide referral for echo or the clinic is natriuretic peptides.
Thanks for taking your time out to speak to me, Ahmet. It's always great to hear you. I always learn something new when you're talking about a condition, even though you've spoken to me because a local colleague, you've taught us all in Darlington a lot more about heart failure, I think, than than certainly the most areas, if not any other area in the country, I think, as a locality. So thank you for that. And thank you for today. It's been great. Thank you.
Thank you. Thanks for asking me, Patrick. Happy to come back and talk about any area of heart failure or anything else.
Great, thanks very much, Patrick and Ahmet, of course, for your insights. Really, really helpful. And I suppose from my perspective, the only thing I would like to highlight is, as with any tests we do in primary or secondary care, we need to trust our clinical judgment, don't we? Trust our clinical acumen. Even if that NT-proBNP is negative, if we suspect heart failure, still do, of course, refer. Same for our cancer pathways as well. So thanks very much, Patrick. Ahmet, very, very helpful. So I thought it might be useful then to discuss what other diagnostic tools we might consider in primary care, namely the role of the chest X-ray and also the role of ECG. So Ahmet, I was wondering what sort of top tips you have, and of course pitfalls to avoid when using both the chest X-ray and ECG as potential diagnostic tools for heart failure.
It's interesting, you touched upon it actually just a second ago. You said clinical acumen, clinical judgment. And I think regardless of the X-ray or the ECG, clinical suspicion is what should highlight what you would do next. These ECG and X-rays are probably just adjuncts that may kind of help look for any other reasons that they might be having the symptoms. So, I mean, taking ECGs, for example, and I see them, kind of every day, almost everyone has them. And I mean, primary care, it's probably not as frequent as the amount I see, but again, there are some things with ECGs that may be of relevance. And things like AF, atrial fibrillation, for example, again, that would, indicate atrial fibrillation means that your management may be slightly different, or might be, you have to think about other possibilities in the setting of what you're investigating and managing with or without heart failure. Also, if you're looking at a few other things, one of the things that you would consider is, and I did this because when I was researching this, actually, I had a quick look, and there's actually an interesting paper looking at this, at ECG changes in heart failure, and we'll have a link with this, actually, just to show you. And it's quite a nice one by the Journal of the American Heart Association. And they looked at ECGs in people with heart failure, so HFpEF and HFrEF, and they found that actually those who had, well, there was actually quite a link with the abnormalities with different degrees of heart failure. And HFrEF was associated with left ventricular hypertrophy, so that quite deep Q waves and quite tall R waves. There's also links with widened QRS, so it takes a long time for the heart to conduct, so the QRS can be quite broad, and that's more associated with HFrEF, and also some ST abnormalities as well. Whereas HFpEF was associated with slightly higher resting heart rate compared to those who didn't have it. So it just again, these are quite interesting because I've not really thought about this more beyond than, okay, if it's normal or not. But actually, there are a few things that you could look for. But again, that wouldn't change. If you suspected heart failure, I would still proceed with the other investigations we mentioned. Now, so in terms of
Fatima's ECG, then 84 beats per minute, regular, some LVH, and some Q waves, wasn't there? Q waves and
yes, Q waves. So it indicates, so some abnormalities as well. And then we didn't mention how wide the interval was, but you'd assume, so there was enough evidence to suggest there is some underlying abnormality there, which would warrant an echocardiogram, plus with that BNP again. So we have some evidence there, and that just correlates with what we know from existing literature and clinical experience. In terms of X-rays, again, it's interesting because from my side in secondary care, I would do the X-ray and kind of have to interpret it straight away almost when that's done, and I wouldn't always have a radiologist looking at it. Whereas from a primary care setting, I imagine you would have the reports sent to you at varying amounts of time. And so really the things you're looking for, I think, signs of congestion, so the heart is not pumping properly, so there's fluid excess, either fluid in the lungs, in the horizontal fissures, or you get dilated upper air lobes and blood vessels, which you can see on the X-ray, and you may get some signs of effusions, fluid in the lungs, or an enlarged heart, essentially cardiomegaly. So those are the things that you'd look out for. And again, that would just, it's all part of a picture, isn't it? A story. You're adding all these things in. So a raised BNP, some ECG changes, some congested looking lung. All these things are in keeping with heart failure, and just strengthens your kind of your diagnosis. Conversely, if you find something else on the X-ray, something different, like something obvious that isn't in keeping with heart failure, that might direct you somewhere else. So both these tests are probably better for, if they're normal, or if they're ruling, or if they're looking to find something else that's going on. But even if they're normal, I would still proceed with clinical acumen.
Good stuff. Thanks. That's really helpful for myself and my primary care colleagues. So I think that Amrit probably might be a good time to round up our discussion about NT-proBNP. We've had some great insights again from Patrick and from Ahmet. Ahmet's been very helpful, ECG and chest X-ray. So I suppose what we want to do next, we've referred Fatima. We want to see what her echo result is, don't we? And what that might show, and what are the implications for a further management. So yeah, what do we do next, Amrit?
Yeah, well, just following on from what you say, Kevin, the NT-proBNP, obviously very good negative predictive value, but not as great a positive predictive value. So it's really now the role of the echocardiogram, which is going to give us real definition here of this diagnosis for Fatima. So as you said, Fatima's been referred. We're waiting for the results of that echocardiogram. And that's exactly what we'll be discussing in our next episode as part of this heart failure series. So we hope we've kept you interested, and once again, leaving you on a little bit of a cliffhanger. We look forward to seeing you in our next episode, when we'll be going through the steps that follow that result. So please do join us then. Guys, thanks again for all your insights. It was great to have Ahmet involved as well in this episode, and we had some wonderful kind of insights from him as well. But for the moment, that's all from us. If you did enjoy this video, please do subscribe to our YouTube channel, and feel free to leave any comments as well, because we'd love to interact with you via the channel or via our Twitter account as well. So until then, take care and thank you.
Bye-bye.
Bye.